Thank you for the introduction. As she mentioned, my name is Rebecca Bowen, and I'm ASHA's Director of Healthcare Policy for Value and Innovation. And we're going to get into part 3 here. Now that we have identified what we're up against as far as policy design and implementation barriers, we'd like to discuss the advocacy initiatives that we're working on to help overcome these barriers and get patients the care that they need. So one lever that we can pull is legislative advocacy. And this means actively working with Congress to shape and influence laws. We find that coordinating visits to Capitol Hill or letter writing campaigns for our members to advocate for or against a specific bill can be an effective strategy. So one example of this is the Improving Seniors Timely Access to Care Act, which was introduced last year and was able to pass the House in September of 2022 with the support of the 3 therapy groups. We're currently waiting to see if it will be reintroduced in the new 118th Congress. So legislative advocacy can be very slow, and persistence and relationship building is key. So you do so much work in a certain Congress to get something as far as you possibly can. And here we got this through the House, and then the Congress term ends and you're kind of restarting the process, not necessarily back to the drawing board completely, but you do have to wait for a reintroduction of the bill. So this bill in particular, we were definitely in support of because it required those Medicare Advantage plans to accept requests electronically for prior authorization, just facilitating and smoothing that process. So instead of having to fax here in 2023, we still had offices who were faxing things back and forth, doing these electronic requests for prior authorization. It also mandated real-time decisions for routinely approved services. So instead of an insurance company getting an authorization request and waiting, having to do that in real time through an electronic system. And it would also require Medicare Advantage plans to provide more detailed information on coverage decisions. So instead of just saying this prior authorization has been denied, we're looking at reasons why, and if there's any way that we can change that decision or have influence on that decision, discuss potentially with a medical provider at the payer to talk through that a little bit. So it's solid legislation. We are in support of it. But again, it's that slow process and that iterative process of we made it this far, we're in a new Congress, and we're going to have to try again. So also on prior authorization, we can talk about another type of advocacy, and that's regulatory comments. So legislation sets out the principles of public policy, and regulation implements these principles, bringing the legislation into effect. So new regulations are released by the federal government as proposed rules. They're open to public comment for a set amount of time, and our organizations often work with each other, with other coalitions, and with member groups to craft comment letters that provide feedback, recommendations, and concerns about these proposed regulations. So when a final rule is released, we are able to see what feedback of ours was incorporated into the final regulation. So the example above, we really focused our comments, and this is again prior authorization, on improving prior authorization through technology to facilitate data sharing. That's a little bit of what we discussed in the last slide. Instead of using fax machines and going back and forth, we have all of that information in the electronic medical record already. So using technology to facilitate that. If the payer needs information on diagnoses or testing that's already been done to support therapy, we're able to do that electronically. Also accelerating the adoption of standards related to social risk factor data collection. So you may have heard the term social determinants of health, and that's looking at factors outside of clinical medical factors that may have an impact on a patient's outcomes or cost of care. So this can be food insecurity, housing insecurity, economic insecurity, even the neighborhood that someone lives in, their exposure to violence, their exposure to outdoor spaces. So looking beyond just those clinical factors to the social determinants of health can also help with prior authorizations and determining who may need additional care and additional services to get the best possible outcomes. We also are looking at clarification of coverage criteria. We want it to be very cut and dry with prior authorizations. In order for a service to be approved, what needs to happen and what information needs to be shared. Sometimes that can be a little nebulous and that can just slow down the process. And then also we are looking to allow qualified health providers besides physicians to review prior authorizations. So, as physical therapy, occupational therapy, and speech language pathology groups, we really want to have providers looking at therapy decisions who have experience in the therapy realm. So, physicians are absolutely wonderful and they know so many things that, us as therapists may not, but we also do have that area of expertise that they don't have a lot of training in. So we really appreciate the opportunity to have qualified health providers in that specialty review prior authorizations. So this is the regulatory side where we're making those comments when the comment period is open and available to the public. Another area that we're really focusing our advocacy on is telehealth. So this really has taken center stage since the pandemic, and we're looking at the reimbursement for telehealth services. So prior to COVID, payment for these services was very rare. It was expanded during the public health emergency, and now we're really trying to hold on to as many of these flexibilities as possible while maintaining consumer protection and the ethical use of this treatment modality. So where we stand currently is the Consolidated Appropriations Act of 2023 extended telehealth authority to treat Medicare beneficiaries until December 31st of 2024. So we're currently advocating for permanent telehealth coverage through legislation that would go beyond that December 31st, 2024 date. So several bills have already been introduced in 2023. So we're keeping an eye on which of those bills is going to be the best for therapy, the most effective, and we'll put our advocacy efforts in supporting those. Another issue with telehealth that we're watching very carefully is telehealth coverage parity versus payment parity. So when we say telehealth parity, many of us think automatically that they're going to be paid the exact same rate, telehealth services versus in-person services. But it can get a little tricky. If we have coverage parity, but not payment parity, all that means is that telehealth services are covered and in-person services are covered. It doesn't necessarily mean it's the same rate. So we're being very careful when we're going through policies to make sure that there is true payment parity between the two modalities of treatment, because we're finding that it really doesn't cost the provider any less to provide telehealth services. It's the same skills, the same experience, the same knowledge. And so we want to make sure that our providers are able to provide those services financially because they are being reimbursed at the exact same rate as they would an in-person service. All right, another issue that we're keeping an eye on is the Medicare Multiple Procedure Payment Reduction, often called MPPR. So MPPR is a per day policy that applies across disciplines and across settings. So for example, if an SLP and a physical therapist both provide treatment to the same patient on the same day, the MPPR applies to all codes billed that day, regardless of discipline. So we're really advocating against this policy because this reduction in payment based on the number of codes that are billed within the same day can really have a negative impact on the most vulnerable patients and undermine this established provider reimbursement for medically necessary services. So many patients who need therapy services have complex conditions. They may require multiple therapy types, speech, occupational, and physical therapy from different providers. So for example, if we have a patient who is having challenges with cognition, communication, swallowing, and is also having challenges with mobility and functional independence, they may need multiple services and multiple codes all within the same day. So what this policy does in an attempt to reduce payment for multiple codes is really disincentivizing interprofessional practice. So the gold standard really is that interprofessional collaborative practice where we can have different providers talking to each other, working as a team, being coordinated to provide the best and most efficient care for a patient. And when we essentially penalize providers for working with the same patient on the same day, it really disincentivizes that interprofessional collaborative practice. It's also very inconvenient for patients who may have to travel into the office on multiple occasions. In order to preserve that reimbursement, we sometimes see providers scheduling physical therapy one day, occupational the next, speech the next. And this is really just a challenge. Patients have functional limitations, transportation can be a challenge, the ability to get in and out of the office can sometimes be uncomfortable, a taxing effort, and for caregivers as well, taking off multiple days of work instead of one day of work to get their family member to therapy is really a challenge. So we've been advocating against this policy, and we most recently developed some sample letters for clinicians in our groups that they can use to advocate with their patients' payers. So if this becomes a challenge, we have those templates that they can go ahead and send to the insurance companies, to the payers, to explain why this policy really is not in the best interest of the patient. All right. Up next, we have cost sharing control. So, unlike a trip to the doctor, therapy visits can occur frequently, sometimes several times a week for many weeks. So, a copay of maybe $50 for a specialist visit is very doable if you're going for a trip to the neurologist. But if you're going to be in speech therapy, let's say twice a week for 6 weeks, that would be $600 in copays, and that can really limit access for many patients. So, we're attempting to match cost sharing to primary care copays. Ideally, we would like to, push that envelope a little bit further so we're not paying a copay at every single visit. But at this point, we have had some success in the marketplace plans, sometimes called the Affordable Care Act plans or Obamacare plans. But that's one venue where we have had success of limiting cost sharing to that of a primary care visit, which is typically much less expensive than a specialty care visit. So speech therapy, occupational therapy, and physical therapy benefit categories have been limited to the primary care cost sharing within these marketplace plans. So that was a win for getting more access from a financial standpoint for those who do require therapy. And then lastly, we are keeping an eye on something called short-term limited duration plans. And we affectionately call these junk plans here in the advocacy world because they're not required to comply with the Affordable Care Act requirements, such as the 10 essential health benefit categories that Kate discussed. And therefore, rehabilitative and habilitative services and devices is not required within these plans. So they are short-term limited duration. So with the contract is for less than 12 months, and the extensions have a duration of no longer than 36 months. But these plans really do offer very limited coverage and benefits. So we are advocating against these because it really is a consumer protection issue where individuals are sold these health plans, but they do not meet the standards of the Affordable Care Act that other plans are subject to. And it can really be a rude wake-up call when the patients who are in these plans need some of these services that they would expect to be in an insurance plan, only to find out it's a short-term limited duration plan and they do not exist there. So working hard against those. So in the fall of 2022, ASHA and AOTA commissioned a proprietary data report examining trends in therapy code use. And we're just looking at how telehealth was being used, and then also the use of those habilitation and rehabilitation modifiers that Laura had discussed. And what we found was a judicious use of telehealth with SLP use, outpacing audiology and occupational therapy, which makes good sense. I think speech therapy lends itself a little more easily to telehealth than maybe the other therapies, or in this case, audiology. But we did find judicious use, which means we didn't see rampant usage of all of a sudden everyone in the world who had never used therapy before hopping on for teletherapy. And that is something that Medicare was looking at very carefully. They wanted to make sure that it was being used appropriately, only with patients that it was appropriate with. And so we found that that did in fact bear out. And then we also found some interesting data on the use of the habilitation and rehabilitation modifiers, in order to track which benefits are habilitation and rehabilitation so that we can count those two buckets separately. And we found that the use is minimal. So it really demonstrates an opportunity for provider and payer education on the use of these codes to make sure that we're accurately capturing the types of services so that people are eligible to have both the habilitation and the rehabilitation. So if we're not using the codes and the codes are not really being required, it's hard to track that information. And then we will run into some of these challenges where, visit limits have been met and we can't parse out what was habilitation and what was rehabilitation. So especially for those with chronic conditions, it's very important that we're tracking the habilitation and rehabilitation codes. So our groups are advocating with CMS for additional education and requirements for these codes. So finally, we want to talk about patient advocacy generally. And with patient advocacy, much of the therapy benefit world is created kind of with a simple orthopedic diagnosis, knee replacement in mind, or maybe an acute injury, trauma to the mouth. So for these chronic conditions, navigating a system to get the amount of treatment from all the disciplines that you need can be really daunting when the system was really designed around something very acute and very time limited. So our goal is to advocate for policies that help our members obtain adequate and holistic care for all of their patients, whether their needs are acute, chronic, simple, complex, debilitation, rehabilitation, or maintenance therapy. So I thank you for your time and attention. And I hope that this was helpful in explaining a little bit about the policy levers that we were attempting to pull to overcome some of these benefit design and implementation barriers for patients with chronic conditions. Thank you.